We'll start with the sessions for the day 2 of the conference. For the first session, that is ECMO maintenance, we have Dr. Jagdish, Senior Consultant in Cardiac Anesthesia and Critical Care at MGM Healthcare, along with us. He'll be chairing the session. Along with Dr. Umaid, he's a Assistant Professor at the Department of Cardiac Critical Care, CTVS Critical Care at All India Institute, New Delhi. Please come aboard.
Good morning, everyone. So we'll be starting the first session, which is ventilation on ECMO. We have Dr. Raghavendra presenting this topic. He is a professor of surgery and the division chief of acute care surgery in Michigan. His area of interest is in global health and inflammatory biology of acute lung injury. So without delaying, we'll start the session.
Good morning. Thank you, Dr. Rao and Bala, for organizing an ECMO-related conference in India. And on the behalf of the Department of Surgery at the University of Michigan, I would personally like to thank you for this invitation. So I just wanted to lay a few ground rules on the talk that I'm going to give. The talk I have been asked to provide is on the management of mechanical ventilation during extracorporeal membrane oxygenator for respiratory failure. I would like to stick to the areas of my expertise and what my clinical practice is, and that is typically in the management of respiratory failure and typically using a veno-venous ECMO rather than a veno-arterial ECMO. I also have very limited experience with lung transplantation. As you will see in the slides that I'm going to show, that we have limited experience with the respiratory failure transitioning to transplant. Most of our patients, if alive, are successfully extubated, and our goal for ECMO is lung recovery. So I'm going to pertain myself to the areas of my clinical practice. With that, I would like to start my presentation. And I know this, I am recording this, so it will be really hard for me to answer questions, but I'm sure Dr. Rao and Bala can give you my email. So if you have any questions on this, feel free to share this questions on my email account. With that, I would go to the next slide. And essentially, what I would like to do here is to give you an idea of our experience with veno-venous ECMO, and there we what our experience is regarding this particular strategy. So disclosures, in terms of disclosures, most of my funding comes from the National Institute of Sciences and National Science Foundation. I do not work with companies, and hence most of the work is related to science and mostly basic research, but I'm not going to talk and bore you on basic research today. So I just wanted all of you to understand that the basic idea about ECMO and ARDS principles, we seem to have forgotten that during the current pandemic. And I would like to reiterate that prevention in the operating room and in the emergency department is key. If you notice that there is a patient with early lung injury, or ARDS as we call it, into a mild, moderate, and severe based on the Berlin criteria, the key is prevention, and prevention in terms of deterioration to a full-blown severe ARDS. And most of the early interventions that we have studied are related to early identification. As you know, there is a lot of data to suggest that lung injury and ARDS is unrecognized for a number of days before we actively think about intubating and looking at all the areas of lung protection that we have learned. We should not forget the importance of low tidal volume ventilation. We should not forget the concept of open lung ventilation, first formulated by Amato and his colleagues. We should not forget all the adjuncts, such as prone positioning and neuromuscular paralysis, which have a significant role to play even following the insertion of ECMO. And as some of the slides I will show, if you look at the long-term data and larger databases such as ELSO registry, you will notice a lot of the adjuncts were still practiced even after the insertion of ECMO cannulation. For difficult patients where you worry about chest wall compliance, think about insertion of esophageal probe and monitoring true transpleural pressures. And finally, we're going to talk a little bit about ECMO as well. So the treatment strategies of ARDS in 2020 or 2021 haven't changed, except that we don't do high frequency oscillators or inhaled nitric oxide anymore. And if you remember the EOLIA study, which basically showed that ECMO is still being used as a rescue. And by and large, if you look at the literature, there is very little data to suggest ECMO should be used for mild or moderate ARDS and prevention of severity of complications. So we use ECMO as a salvage therapy, as a rescue therapy for severe ARDS, and that's where we will concentrate on. We prefer veno-venous ECMO for respiratory failure. I'm sure you guys are very comfortable with the idea of understanding veno-venous ECMO. If the patient is really sick and cannot be moved to the operating room, we will do a bicaval cannulation, right? IJ preferred, and one of the groin lines preferred. We make sure that when we are inserting cannulas through the groin, they are closer to the insertion of the hepatic veins so that we can get a good outflow. If the patient is relatively stable and we think we can safely transport the patient to the operating room with fluoroscopy, we are able to put an Avalon cannula. We do not have the capability to do a bedside Avalon insertion because the fluoroscopic units and the radiation protection that is present in the ICU is not robustly developed in our ICUs. So that's why we prefer doing the Avalon cannulation in the operating room. So I just want to go through the ELSO registry. For those of you who are already familiar with many of the talks, I'm sure they have talked about the ELSO registry. So the current data, actually, the numbers are significantly up and their mortality is close to 50%, but this is the original publication in Lancet in 2020. And they had a mortality of 40%, and obesity and the diabetes were the largest risk factor. And the median duration from ECMO, endotracheal intubation to ECMO was 4 days. That means the patients who are going to deteriorate likely deteriorate earlier. And the median duration of ECMO is about 14 days. And this is a number that I want to talk about, and that is 50% of the patient had tracheostomy. So which is part of what we are currently doing when we see patients with COVID. After we put the VV ECMO, once they have stabilized, we will consider a very early tracheostomy. So what have we doing at the University of Michigan? As you all know, we are in the 4th COVID wave at Michigan. This started all in March, April of 2020, and it's still continuing. We have these waves where we receive a lot of patients from our outside hospitals. As you can imagine, the hospital is trying to balance out the financial recovery from lack of ambulatory surgery. So the number of patients that we are able to place on ECMO is limited compared to the early pandemic where we have a 21-bedded ICU And during April, May, and June, all 21 patients were COVID, and all 21 had ECMO. Once again, I want to reiterate, as I explained in my original introduction, our primary goal is not lung transplant, it's lung recovery. And we still have a very incomplete understanding of the risk factors in addition to diabetes, African American race, and obesity. There are some other risk factors that have also been outlined in the current literature. The patient that we chose were between 22 to 65. I'm sure you are familiar with the concept of silent hypoxia, which accounted for a significantly large mortality when published series from New York was evaluated. And essentially, a lot of these patients manifested very little signs of hypoxia. And only when they were subjected to a pulse oximetry and other evaluations, we noticed that they were significantly hypoxic. Luciano Gattinoni also in the earlier paper described the two different varieties that we saw during COVID, and that was a low and high elastance varieties. We typically only saw the low elastance varieties, which is conventional ARDS. And we are routinely anticoagulating all these patients, as you know very well. Levels of vascular endothelial growth factors and what is called as intussusceptive angiogenesis occurs in these patients with COVID. They are highly thrombogenic, and we routinely manage them with anticoagulation. So this is a new paper that just got published, and I'm sorry you're not able to see the writing on my right, but this paper just got published in November 2021. This is the Rush group in Chicago, and what they noticed was that if they are able to perform extubation following a tracheostomy on ECMO and subsequently decannulation, they had a significantly higher incidence of discharge, and as you can see, almost 68% survival. Currently, what we are doing at the University of Michigan is we are considering early tracheostomy. We are avoiding benzodiazepines because of their high association with delirium. Prevention of de-recruitment is extremely important. I'll talk a little bit about it when we talk about mechanical ventilation strategy. And our overall survival to lung recovery is about 60%, slightly less than the Rush group, but I'm sure risk stratification and the risk patients are also important. So I wanted to once again emphasize, not sure whether you're able to see the little writing on the text box, we did not transition any patient to lung transplant. And our optimal and primary goal was lung recovery. This is few of our patients that I took care of personally in May and June. And as you can see, they've done well and gone on to recovery and rehabilitation and actually back to active life. So what are the basic principles of mechanical ventilation during ECMO? So the basic principles of mechanical ventilation during ECMO is to prevent ventilator-induced lung injury. And what it translates into is to prevent alveolar strain. That is, we have this volute trauma, barotrauma, and what we call as atelect trauma, which is nothing but prevention of alveolar collapse and recruitment at every respiratory cycle. So to prevent ventilator-induced lung injury, the general idea here is to prevent alveolar strain. And how do you prevent alveolar strain is by reducing tidal volume and reducing PEEP. Of course, there is a happy medium between reducing PEEP, and I will discuss that in the next few slides. It is incredibly important to remember that if somebody who has severe ARDS, who has hepatization of the lung, the areas of aerated lung are incredibly small. That means the normal alveoli itself are small. So hence the pressure volume curves are reflected at a much higher exaggerated scale. What does that mean? Small increments in tidal volume, small increments in pressure have a significant impact on the lung because there is very little lung that is actually aerated. So you have to be very careful with modulation of pressure and volume during ECMO. The other part to remember is there are two different types of strains. The static strain, which is generally manifested by PEEP, and the dynamic strain, which is generally manifested by tidal volume. And I can explain as we go along. So before I like to give you an idea of what we are doing and what is the optimal strategy for mechanical ventilation on patients following ECMO, it's a good idea to stop and review the literature. So if you look at the ELSO guidelines that were established, they basically suggest using an FiO2 of less than 0.4 and a plateau pressure of less than 25. Now, just remember, these are guidelines. They are written by people like you and me, and we don't have a full understanding of why these guidelines were inserted and what is the evidence based. There are two large studies that anybody who has done ECMO talks about. The CSER study, which was done in the UK. And unfortunately, the CSER study did not have any documentation of what the ventilator settings were following the insertion of VV ECMO cannulas. So pretty much that is not very helpful in figuring out the appropriate guidelines for mechanical ventilation. However, in the EOLIA study, tidal volume was targeted to keep the P-plat below 24 in conjunction of PEEP of at least 10 and an FiO2 of 0.3 to 0.5. Makes me think that the ELSO guidelines were directly transposed based on what we found in the EOLIA study. So this is an important thing to remember, that how we are targeting P-plats of below 24 and the plateau pressures of below 24 with the PEEP of at least 10 and FiO2 as low as possible. Just to briefly recapitulate, the EOLIA study was essentially done to figure out whether ECMO should be inserted early during the course of ARDS or it should be preserved for a later following failure of all other conventional strategy. And essentially, we know that there was no significant differences in mortality. So most of the world has gone towards ECMO has become a rescue mechanism for patients with severe ARDS. And most of us, at least in the West, are opting for lung recovery. This is a new data that was published in 2019, where they looked at what should be the mechanical ventilation treatment during ECMO. This was, of course, a retrospective study, though they are calling it a prospective cohort. They looked at a lot of patients in 23 ICUs, and they looked at what were their overall mechanical ventilation patterns. And what they interestingly found was most people, as soon as you put them on ECMO, were transitioning to an ultra lung protective ventilation with very, very low tidal volume. However, the study also showed that mechanical ventilation setting during ECMO had no impact on patients' prognosis. And the study went on to examine two groups of people and essentially divided them to survivors and non-survivors. And as you can see in the graph above, there is no difference between the patients who underwent what is called as a higher mechanical power, as well as tidal volumes. As you can see, they were all 3.5 to 3.7 ml per predicted body weight, which is, as you can imagine, really low tidal volume, and there was no significant difference in the survival. Going on to further examining these patients, and this is you can see that as soon as ECMO was inserted, both the driving pressure as well as the tidal volume. So driving pressure is nothing but the difference between the plateau pressures and PEEP, and the tidal volume, there was zero differences between mortality, because after a certain stage, you can see that both the survival curves started merging. So what does this mean? Essentially means, regardless of what you do with mechanical ventilation, the strategy that you employ for mechanical ventilation following insertion of an ECMO cannula has little effect on overall survival. And overall, it is the severity of the disease that designates the prognosis. I was also briefly asked to touch base on the ECMO and bronchopleural, the role of ECMO and bronchopleural fistulas. As you know very well, bronchopleural fistula is a major problem and potentially related to barotrauma, related to high tidal volume or high pressure ventilation. And as you can imagine, prevention is key. And once the bronchopleural fistula happens, and once you're losing a tidal volume of approximately 30% of what you are put your mechanical ventilators on, there is little you can do other than continue with lung protective strategy. Obviously, things become easier once the patient receives extracorporeal membrane oxygenator, and once ECMO is initiated, then most people will reduce the transpleural pressures. And the way to do that is by reducing your delta P, the difference between the peak pressure and the PEEP, to a very low level. Now, there is always this controversy as to which of these pressures are more important. Is it the PEEP or is it the delta P? Most recent data would suggest it's just PEEP alone is not as significant as the transpleural pressure that determines the closure of these fistulas. And the data that I'm showing you is from a recent paper where they dropped the tidal volume significantly. They reduced the transpleural pressure significantly following the initiation of ECMO. And they had a significant amount of spontaneous closure of the bronchopleural fistula. The other strategy that has been discussed in the literature is surgical repair of the bronchopleural fistula, especially if it is done in the setting of a lobectomy or a segmentectomy for lung cancer with ECMO support and subsequently weaning off the ECMO support. Of course, we have to balance out the risk of thoracic bleeding and the need for thoracotomies and repeated thoracotomies that happens occasionally following initiation of ECMO. So this is an important slide. I would like to talk briefly about the ventilated settings, and this is sort of a consensus statement. And the general idea that we have learned is once ECMO is initiated, we are in no hurry to completely reduce the tidal volume to 10 cc's or 15 cc's total. What we do is we reduce the transpleural pressure, we reduce the delta P to an extent that it is acceptable and keep the plateau pressure less than 24, 25, fully understanding that in a normal person, we keep the plateau pressure less than 30. And as we joke in the ICU, the new 30 is 28. So what we are trying to do is mitigate the amount of ventilator-induced lung injury by reducing the amount of pressure and volume on a small area of lung that is not affected by ARDS. We are also cognizant about PEEP. We are totally comfortable increasing the PEEP, but the target of PEEP is not oxygenation. It is more the mechanics of the lung. Remember, a lung that is inflated has the best mechanics. The lung that is deflated and collapsed has some very poor mechanics. And as you know very well, with ECMOs, we can tolerate very low saturations. Our typical target for saturations following ECMO initiation is about between 86 and 88%. So continuing on the recommendations, what we do once the patient is placed on ECMO for respiratory failure, we prefer pressure control mode. And as you know, the flow is much higher with the pressure control mode compared to volume ventilators. And we also have the ability to raise the I time so that we can appropriately address oxygenation deficits. We will keep the tidal volume lower than 6 ml. We try not to go as down to 3 cc's, but we do that by decreasing both the plateau pressure and driving pressure. And if we get a tidal volume between 4 and 5 ml per kg body weight, as long as the pressures are not high, we feel very comfortable doing that. In terms of respiratory rate, the ELSO guidelines in the past have suggested a rate of 5 to 10. And the logic there is the respiratory rate with the cyclical trauma to the alveoli is also a contributor of ventilator-induced lung injury. We do it a little more carefully, and what we try to do is gradually adjust the respiratory rate so that hypercapnia and hypocapnia are appropriately addressed, and the pH stays between 7.25 to 7.35. Most times, most centers will gradually reduce the FiO2. The goal is to have the lowest amount of FiO2 possible. And once the ECMO is stabilized and once we feel that the lung recovery is happening, that's the time we gradually increase the FiO2 and the plateau pressure and the PEEP and gradually start reducing the ECMO, as our primary goal is lung recovery and removal of ECMO cannula. Now, PEEP is much more complicated in the setting of mechanical ventilation following ECMO. The reason is PEEP is multifactorial and PEEP has multifactorial effects on the hysteresis curve. So it all depends on where you are on the pressure volume curve. If you are on the hyperextension or high pressure, low tidal volume, trauma area, obviously you have to have a different strategy compared if you're much lower on the hysteresis curve. So what we typically will do is we will increase pressure with PEEP, fully understanding that there is some degree of alveolar recruitment we want. So one of the things I earlier mentioned was the prevention of de-recruitment. We used to have a strategy where we cut down the tidal volume to 100 cc's, 200 cc's as soon as ECMO is done. We do not do that anymore. What we are currently doing is reducing the amount of driving pressure to less than 24 and see what the tidal volumes are. If they are low, that essentially tells us that there is significant disease in the lung parenchyma. So we will typically use PEEP as tolerated. They will range anywhere from 10 to 20 as suggested by the Joliard study. And more importantly, we take a very acute look at the effects of PEEP on the venous return. And if necessary, we keep the volumes up so that the ECMO circuit does not keep chugging all the time. And so one of the ways we adjust PEEP is not just for the oxygenation, but for mechanics of the lung and the effect on a venous return. In addition to suggesting a few recommendations here, it is extremely important to talk a little bit about respiratory monitoring and what are the goals of respiratory monitoring. We monitor the function of the native lung, and typically we will do that with gas exchange, lung mechanics. We do the Silly test, where we will completely increase the FiO2 from 50 to 100% and look for gains in oxygenation. And if we find that appropriate Silly test, then we will start trialing people on off ECMO cannulation. The other thing that we are doing during the COVID pandemic is because there is high risk of thrombogenesis, we are keeping the blood flow rates on a higher side. So we keep the flow rate in the ECMO cannulation higher. And even if we are trialing off the circuit by removal of any PEEP or capping off, what we will do during that time is we will keep the flow rates going at a high rate. And that reduces the risk of thrombogenicity in the circulation as well as around the membrane. So this is something that we've been doing for many years. We also guide our ventilator setting, and as I said numerous times during the talk, the general idea is to reduce ventilator-induced lung injury and promote lung recovery. And obviously, we look for monitoring of complications. Typically, we'll get a blood gas 3 times a day, a chest X-ray once a day in the morning. We also monitor these patients for free hemoglobin, as well as evaluation of the circuit, which is performed at least 4 or 5 times a day by ECMO specialists. By and large, in our ICUs, ECMO patients are taken care of by just nurses, and the ECMO specialists are available in case there is any problems. And with that, I would like to end my talk. Once again, I thank Dr. Rao and Bala for having invited me to this talk. Here is my email. Please feel free to write to me if you have any questions. And thank you so very much.